The process of applied functional science is the transformation of the notion into the motion.
From the Gray Institute, this is the Gray Institute podcast. Gray Institute is internationally acclaimed for its innovation, development, mastery, and delivery of applied functional science, AFS. AFS is based on scientific truth, not theory, of how the human body moves in all three planes. AFS allows movement professionals like you to apply the best, most effective, and most efficient movements to any individual based on specific needs and goals. For 40 years, through training, education, and mentorship, Gray Institute has equipped over 150,000 professionals with comprehensive knowledge in the principles of applied functional science, AFS. Whether you're physical therapists, personal trainers, athletic trainers, chiropractors, strength and conditioning coaches, physicians, physiotherapists, occupational therapists, osteopaths, physical therapy assistants, or kinesiologists, our goal is to help you become the go-to movement professional.
Welcome, amazing viewers, to yet another webinar delivered by Gray Institute. If this is your first webinar, I hope you're going to get a lot out of it. If this is your second, third, or even fourth webinar by Gray Institute, welcome back. As you can see, we get excited about delivering this type of content because this content needs to be delivered to the movement industry, because the movement industry is special. It includes you. It includes someone who cares dramatically about the person in front of us. So on behalf of Gray Institute, I just want to welcome you to this webinar, which is entitled ACL, Functional Biomechanics and Applications for Prevention, Performance, and Rehabilitation, Part 1. Now, the topic of the ACL is a big one, especially in sport, but really in everyday life because it pertains to the important knee. Now, as you may have seen through our marketing materials, we directly kind of stated something to throw people back on their heels a little bit, but we meant every word. The knee over the foot is not going to work. It's not functional, and it's not the best way to go when we're looking at treatment and training and doing our best to even prevent an injury, of course, to the ACL. The topic has to be viewed through the lens of applied functional science. So to deliver this topic, we made a strategic decision to not recreate the wheel. In fact, we wanted to provide you the wheel. What's the wheel? The wheel is a chunk, a segment from one of our recent virtual chain reaction seminars. Now, chain reaction has been going on for well over 30 years, and it continues to get improved each and every year. And one of the biggest improvements is kind of synthesizing the 45 plus years of Gray Institute experience into the ACL. And so that's what we wanted to deliver here in this webinar, because we want to dive deeper into the ACL and kind of focus on it more as an elevated type of case study. So this particular chunk and segment was pulled out of our virtual chain reaction from the second half of the day in day 2. Now, I know what you're probably thinking. I'm missing out on so much more if there was a day and a half of information up front. Well, yes and no. Because the way that Gary delivers this content is brilliant. And it doesn't require that you know the first day and a half of information, because the goal that you're about to see is going to be understood and hopefully directly applied, not only in part 1, but when we get into part 2 a little bit later on our timeline of this year. So what are you about to see? Well, there's 3 big rocks. The first rock is what truly causes the ACL to tear, understanding and appreciating the anatomy of the ACL and the body's influence on this vital part. Now, the second big rock is going to be the distal knee and the proximal knee, how the foot and how the hip influence and impact the ACL. And then the third big rock of this webinar is going to be the function of the trunk, how the thoracic spine influences and impacts the ACL. So there's going to be a lot here, which of course is why if you're watching this on the on-demand premiere, we're giving you 2 days to view it because of the 90 minutes that this includes. Now, if you kindly registered for the on-demand premiere, you're automatically going to be registered for part 2, which I think you're going to appreciate so you don't miss out on it. But I'm guessing that you're not only going to appreciate the application part, but Gary's going to whet your appetite through the gold of part 1 to get to even more gold, more applications, more progressions for the ACL in part 2. And that's going to be the focus of part 2. But now we're into part 1. I also want to just thank you again for joining us here, as I'm excited for you to watch what I've already watched of Gary's brilliance talking about the ACL. And if you're watching this with the on-demand premiere, just make sure you stick around at the end for the exclusive special offer. But without further ado, I present to you Dr. Gary Gray and the ACL. Enjoy.
One of the many benefits that you have in understanding your chain reaction biomechanics is you can appreciate the part and you can appreciate the whole. You can appreciate the part as it relates to the whole and how the whole relates to the part. And you're going to see that your understanding of your chain reaction biomechanics is going to pay great dividends as we together try to understand the anterior cruciate ligament. Now, I'm not sure if there's a ligament in the body that's talked about more than the anterior cruciate ligament. We can be watching a basketball game and all of a sudden see somebody come down with the rebound and their knee kind of takes off in a direction it doesn't normally take off. And even the announcers will start to hypothesize, I think they might have torn their ACL. It's quite common. It's common to see. It's common in us understanding that, we rehab a lot of those after ACL surgery, but it's not so common to say, I wonder what really causes the anterior cruciate ligament to tear. Now, in a lot of our chain reaction seminars, I'll get a little dorky and I'll talk about in transformalizing and being either the ACL or the PCL, the posterior cruciate. And that we wake up and all of a sudden realize there's been trauma, and that so much trauma that I don't know which one I am. And then I ask the other thing that's there, the other thing that in transformalizes, so who are you? And I selfishly wanted to say, well, I'm the ACL, therefore that would make me the PCL. And the reason I say that is because it's very rare that the PCL gets torn. Now, that's kind of offers us the very first question. If they live in the same neighborhood, and obviously they cross, creating a crucifix or the cruciate component of the cruciate ligaments. But the big question would be, why does the ACL get torn and the PCL not as often? In fact, way down less often. In fact, usually you can relate it to an acute trauma, what they call a dashboard injury, where all of a sudden the dashboard takes the tibia and drives it back and it tears the PCL. Or I'm on skates, and this has happened to me, where I don't stay up on skates and all of a sudden I fall and all of a sudden my tibia runs into the goal, the edge of the goal, and yet drives it back. Yeah, that's a PCL tear. But very rarely do we hear much about the PCL. We always hear about the ACL. And of course, in applied functional science, we always like to ask, I wonder why? Why is that? And we're going to investigate that. And our understanding of that is going to allow us to really understand what we're going to do to take great care of our friend, the anterior cruciate ligament. Now, as you know, the triadox in applied functional science of prevention, performance, and rehabilitation, it's a triangle. It's all the same thing. But we know that once we understand human movement, slightly tweaked allows us to approach it a little bit different, but not what we would call globally different. And therefore, the ACL is the same. When we talk about rehabilitation and we talk about performance, we're also talking about prevention. Now, I know a lot of people go, oh, you can't prevent an ACL tear. That's correct. We can't guarantee that if we do this and this and this, that we're going to prevent it, because there's too many forces out there during a game, so to speak, that we don't have control over. But we definitely want to control those that we have control over. A lot of new statistics reveal to us that ACL tears now most commonly occur without an external force. Which simply means back in the good old days, we always thought as you're running with the ball, somebody's going to have to come and take you out to tear the ACL. That still happens. But the greatest percentage of ACL injuries, there's nobody around. Just the person, the ground reaction force, massive momentum, and gravity are the forces and the things that are there that create the anterior cruciate ligament tear. Now, let's go back to our first question, and that is, if the ACL and the PCL kind of live in the same neighborhood, why does the ACL get nailed? Well, first of all, with the anatomically, I have the left knee here, I have the left foot, and I have the left part of the left hip. Now, what's neat about this is that if you look at the knee, and I didn't give you nomenclature of different body parts. Somebody that was really brilliant, let's say somebody that's in kindergarten, first or second grade, if I said we're going to talk about this, they would immediately say, well, it looks like this is a big part of that. Well, it is. It's this long bone called the femur. And if I showed you this, they'd say, well, it looks like this is a big part of that. Yep, it's this long bone we call the tibia that hooks onto the foot. And so without getting an isolation kind of mind, just stepping back and going, so what's going on here? And also appreciate we're going to have to hook this baby right into the pelvis, and then we're going to have to hook it into the trunk and the rest of the body. Because what we're going to find out is a lot of what happens up at the shoulders and in the core directly influence our friend, the ACL. And we need to understand that if we're going to do the triadoxical approach of prevention, performance, and rehabilitation. Looking at the ACL, we know that it kind of starts way up here in the intercondylar notch on the lateral side. Again, this is a left knee, and it juts down obliquely, anteriorly. That's where it gets its name, anterior cruciate. But it also goes medially. It should be actually called the anterior medial cruciate, because that would give us a little more hint as to what causes it to tear. Now, the posterior cruciate kind of crosses it a little bit, but it's kind of up in the intercondylar notch, but it goes a little bit posterior, not at the same acute angle that the anterior cruciate does. So when you go in there and look at a cadaver, that ACL, boy, that thing has a big angle to it, kind of sneaks up under there and grabs right into the tibia, where the PCL kind of doesn't have that much of an acute angle. Still a little bit oblique, obviously creates a crisscross to the ACL, but it's just not kind of that big acute angle that we see, and we kind of go, that's interesting. Wonder why that is. Now, one of the fallacies that we got to kind of set aside right now, or at least identify and then set this sucker aside, is that when we do have an ACL deficit knee, and we clinically go in, there's a number of things that we do to clinically see if it's there, including an MRI. Now, MRIs are making our life a lot easier these days, but clinically, I always want to know what's going on there. And we have this thing called this anterior drawer. Now, we can do this anterior drawer with the knee partially flexed, which if they're laying down, we sometimes call that a Lockman's test. We can do it with the knee flexed a little bit, so the person's laying down in their knee, and we're kind of doing an anterior drawer. We also do an anterior drawer with the lower leg, in this case, externally rotated, and we also do with it internally rotated. Those tests basically are saying if you pull forward on the lower leg, the proximal lower leg, if that anterior cruciate ligament isn't intact, and also many times includes some capsular tearing, that we're going to get a laxity. The problem with that is years ago, we thought, well, that must be the force that tears the anterior cruciate ligament. So back in the day, back in the 70s and 80s, when we were improperly, I'll emphasize again, improperly putting people on knee extension and knee flexion machines like isokinetic machines, we kind of thought that, well, if this muscle we call a hamstring here, we can strengthen it. In fact, we even sometimes were asked to strengthen it even greater than the quadriceps, so we'd have a greater hamstring to quadricep ratio, that could prevent the forward translation of the tibia on the femur. We based that on the fact that when nothing was going on, that is the test that would reveal that we had an ACL that was not intact. We were misled, severely misled. That's not the force, that's not the motion, that has nothing to do with an ACL tear. What causes it? Another way to look at that is if you're familiar with looking at ankles, and this again is a left ankle, and I have what we call a grade 2.5, grade 3 lateral ankle sprain that involves the anterior talofibular ligament and the calcaneal fibular ligament. And if I take this and I pull on this, I'll have what's called a positive anterior drawer to the ankle. But we didn't all of a sudden say, well, it's that force, it's that motion that tears it. We know that, no, that's just a clinical test. What tears it is a combination of an inversion, and plantar flexion and adduction, a three-dimensional stress to my left ankle that tears that, and clinically we can see that by applying this force. Same thing with the anterior cruciate ligament. We got to look at that and say, if you had a nice strong ligamentous structure that angled that way, that went anterior medial, what could happen to cause it to become disrupted? Well, it's pretty easy. If this was a Lego set and I had like a rubber band that was the anterior cruciate ligament, I literally could hand this to my grandson and I would say, can you tear that? And he said, sure, I can tear that. He would take it and see that it was hooked right here, and he'd say, well, all I have to do is this. And he would be correct. What he just did is internally rotated the tibia on the femur. Or he would see this angle like this and he'd go, oh, I can see the tension even as much if I did this. So he would actually create a valgus stress or abduct the knee and create a lot of tension and tear the rubber band, in this case, the anterior cruciate ligament. And then he'd say, well, if I really wanted to get it, I'd do both at the same time. And I said, well, what do you mean by that? Well, I would actually create internal rotation and I would create abduction at the same time, and I would tear it. And all of a sudden, my heart starts fluttering because I go, whoa, I've heard that combination a number of times during our chain reaction talks. I've heard it when we talk about the foot, what it does to the knee. I've heard it when we talk about the hip, what it does to the knee. I've heard it when we talked about the knee, what it does to itself. I've heard it anytime we talk about gravity. I hear it anytime we talk about ground reaction force, and I hear it anytime we talk about mass and momentum. And therefore I go, oh man, I think we're getting a hint as to potentially what is the cause of an ACL tear, and why does the ACL tear a lot more than the PCL. Now, if I have to really go through a lot of aggressive external rotation to get, because of that lack of the oblique angle, the PCL to tear, and I would have to put a lot of varus stress on there altogether to get that to tear. So I could do that if I had a lot of external rotation of the tibia on the femur and a lot of adduction or varusing, so to speak, of the knee. But that doesn't ring a bell. My heart doesn't pitter patter. I don't go, ooh, that's kind of increasing my pulse rate, because I think that happens a lot. That doesn't happen a lot. Very rarely in function do we get too much external rotation at the knee, and especially combined with any adduction. And we'll talk about that in just a second. So here's what we know. We know that one of the, I love this kind of concept. One of the terms of an ACL tear at the knee is what's called a gravitational induced tear, which means it seems that gravity pushing down on the body forces the foot to do something, forces the hip to do something, has to, because that's the femur and that's the tibia. which of course forces the knee to do something to tear the ACL. And so what is that? Well, you already know what that is. It's a combination of internal rotation and combination of abduction at the knee that takes it beyond the range. Now, we're supposed to have a little bit of that with function, but beyond the range that it can tolerate, and all of a sudden the ACL kind of rolls its eyes and goes, crap, my buddy the butt let me down, my buddy the trunk let me down, my buddy the other leg let me down, my buddy the foot let me down, my buddy the hip let me down, and guess what? I'm going into this dangerous zone where the only thing I can do is tear. And then we have to step back and go, so what caused it to tear? Well, just the concept of gravity should ring big bells in our chain reaction mind, because just with walking, we know that when we walk, and again, we're going to reference, and I'll try to be kind of specific at this, at what knee we're referencing, because sometimes I'll confuse you, and I don't mean to, but in this case, we're going to be talking about the left knee. Is that in walking, we know that when my foot hits the ground, you already know that foot collapses and that calcaneus everts and that talus falls down and in, and the tibia what? Internally rotates. All of a sudden, the ACL with that motion will say, oh, I'm being lengthened. In fact, we want it to, because it has proprioceptors that let everybody in the area, and even a lot of muscles. We know those Golgi ligament endings go to different muscles to say, please turn on to help decelerate this motion, because if you don't, I'm going to tear. And we go, oh. And then we also know that with that same motion at the knee, that's facilitated by the movement of what we call that ground reaction force of the foot entering into the ground, we not only get that bottom-up internal rotation of the tibia on the femur, but because we get this adduction at the hip and we get that eversion at the foot, I'll exaggerate it here, adduction here, eversion here, it shows abduction, or a lot of times I like to call it valgusing, wrong term, but the heart's in it because it shows a valgus angle, and all of a sudden the ACL goes, that's that motion that if you keep that up, especially if you kind of combine it with too much internal rotation, that's going to tear me. And then I go down there, and if I transformalize and I say, yo, anterior cruciate ligament, who's to blame here? And the anterior cruciate ligament gets a smile on his face and says, you know, I got to tell you a little bit about myself. I have lots of friends. I have more friends than people even understand or appreciate. But that's a blessing on one hand and a curse on the other. And I go, how can it be a curse? How can having too many friends be a curse? And the anterior cruciate said, well, without wanting to, sometimes my friends let me down. And when they let me down, they basically are the cause of the abnormal motion at me, but it came from them. In other words, they really did it, but I took the hit. I go, well, kind of step back, my heart pitter-patters again, because I know as a friend, I've let a lot of my friends down. And sometimes it's just out of ignorance, sometimes out of laziness, sometimes it doesn't matter. But I know I feel sick when I do, and especially when I finally realize that I did. And the anterior cruciate ligament says, no, I understand. But it takes a lot of us to decelerate gravity and ground reaction force and massive momentum all at the same time to keep me safe. And that's the ACL says, that's why I get nailed so many times. That's why I have, so people write journals about me, articles are written about me, and the ACL says, all I want you to truly understand with your chain reaction applied functional scientist mind is understand the motions at my knee joint that are associated with the motions of my buddy, the foot, and the motions of the hip, and the motions of the other hip and leg, and really the motions of the trunk and of the arms, that if those motions facilitate abduction and internal rotation, I need you to understand what motions then load motions to decelerate what's happening at the hip, what's happening at the foot, in order to decelerate abduction and internal rotation. And we go, oh, that's just a little more complex than just thinking that maybe this weird anterior translation force is causing you to tear. And it kind of giggles and goes, nah. Very, very rarely do gremlins sneak up behind me and kind of push on me and all of a sudden cause a distraction there. It's gravity. It's ground reaction force. It's mass and momentum. It's all my friends not synergistically decelerating that motion, which we call loading, in order to make me safe and explode or unload and be able to do something else. And the ACL would say, you can actually, I'm kind of famous on YouTube. In fact, you can go to YouTube and type in ACL injuries and you will get sick to your tummy because you'll see me, the knee, undergo motions that I should have a little bit of, but not a lot of, and all of a sudden I will tear. But what I want you to do is I want you to appreciate immediately what happens just below me at the foot and above me at the hip in order to really appreciate what's causing that abnormal internal rotation and abduction at the knee. And we go, okay, that's a big hint. Big hint. And it will say, you need to know that so you know initially what's safe. In your training programs, in your performance and prevention programs, and certainly in your rehabilitation programs, the ACL says there's a lot of things you can do at the hip. There's a lot of things you can do at the foot that'll give me just a little bit of input. It'll actually create the reaction I need to create good mobility and good stability and good proprioceptive enriched feedback, instead of just kind of letting me stay dormant and make it very safe, because you're going to be staying predominantly in the sagittal plane. And if you do go in the frontal plane, you're going to take me away from abduction. And if you do go to the transverse plane, you're going to take me into a little bit of external rotation. You're not going to take me into internal rotation. And we go, okay, I think I got it. So kind of just understanding and then transformalizing and becoming that anterior cruciate ligament. It says there's a lot of things that have to come together to allow me to successfully enter into the ground and decelerate that abduction and internal rotation and then explode and go and do something else. And therefore, that's why you very typically see when my knee takes off, my buddy takes off into that frontal and transverse plane too far, that's when I get torn. But don't look at me, the ACL would say, don't look at even the knee really. Look at what caused it. Look at what happened proximally to me at my hip, distally to my foot. And what we're going to see as we explore it even more, a lot of what's happening at the trunk that causes that ACL disruption.
Download the Gray Institute app for exclusive access to resources, training tools, and community. At Gray Institute, we pioneered the field of applied functional science. Now we're excited to offer exclusive updates on movement science, best practices, and other resources to our Gray Institute community of professionals. Our app offers practical tools that can improve both your practice and your client or patient performance. Our app offers powerful tools including access to the Home Fit app, exclusive community forum, webinars and extensive resources, and it's free to download. Download the Gray Institute app today, available from Google Play and the Apple Store.
Again, remember, what's good for the performance, what's good for the prevention is good for the rehabilitation. And those progressions are very, very consistent. The difference is, after a surgery, the progressions are a little bit slower. With performance and prevention, same progressions. We want to start very safe and very, what we call functionally stable, but we want to move fairly quickly based on their abilities. And we'll see that as we progress and looking at the different movements that causes the different motions to the knee, and constantly say, hey, with our chain reaction biomechanical knowledge, ACL, we're going to appreciate all your friends, and we're going to see if we can get all your friends to help you enjoy a very safe and effective and efficient and proficient life that you can enjoy without any harm to you. So the anterior cruciate ligament simply says, hey, to really understand and appreciate me is to understand and appreciate my friends, because they are the ones who drive me, along with that gravity we talked about and that ground reaction force. And of course, the real big one that we sometimes underestimate is the mass of momentum. I'm already moving, and the ACL, kind of look around and say, okay, who's going to slow down all this mass of momentum in addition to this gravity and this ground reaction force? And I look, of course, to my friends. Now, an obvious friend that I have that I think we're really finally, after years and years appreciating the dominance the foot that has on me, the knee, is appreciating that when the ground enters its force into our body, it's through our foot. And when gravity throws our body into the ground, it's our foot that hits the ground that sets the knee, the hip, the rest of the body up either for success or potentially failure. And therefore, to review our chain reaction biomechanics of the foot is critical, because that'll give us guidance as to, so if we're going to start a progressive program to make the knee and the ACL and the rest of the body as safe as possible, we got to know what the foot is doing to the knee, and then we'll talk about the other friends as well. So when we take a look at the foot, as you remember, it's magic. When it hits the ground, it becomes mobile, and when it propels, it's already become rigid. And it does that by going through this motion. And again, I'll reference the left side. I'm going to try to stay left-sided on this during this entire series, so we don't get confused, or at least I don't get confused. But we know when the foot hits the ground and the calcaneus everts. Why does it evert? Gravity, ground reaction force, mass and momentum. So there's not a muscle that does that. It everts the heel, and we know that the talus falls down and in. And as soon as that talus falls down and in, because it's wearing a hat that we call the tibia and the fibula, it has to follow it. It's impossible not to unless we dislocate our ankle. And so I'm on top of this talus, the tibia and the fibula say, and when I feel that thing fall down off the horse, Calky the horse, I go down there. So immediately we have the tibia internally rotating faster than the femur, because at that same time, the femur is also internally rotating. But because it's happening from the ground up, the tibia is going faster. I, the ACL, sense that tension. I get lengthened with internal rotation. So just with that normal gait mechanics of the calcaneus everting, some people will call that global motion pronation. That normal amount of pronation creates initial good hit. In this case, it's a good amount of motion of internal rotation of the tibia on the femur, because the calcaneus has everted. Now, to contrast that, if I have the ability now to invert the heel, which you'll see takes a lot of friends to do that. When I invert the heel, the talus climbs up on top of the calcaneus, and now it forces the tibia to externally rotate. So if you were to stand up and just do this, put all the weight on your left leg and just roll your foot down and in, you'll see that not only do you have this rotation going on, but you're going to feel a tension in the anterior medial part of your knee. You should, because it's internally rotating, and we'll find out it's also abducting or valgusing. But contrarily, if you then invert your heel, just ask yourself to just roll to the outside of your foot, immediately you see the opposite response of your knee. You now see, instead of all the forces going this way, that the forces are going that way into adduction or varusing. Now what I have is I have the tibia externally rotating faster than the femur's externally rotating, and therefore I have external rotation. The anterior cruciate ligament, because of its angulation, goes, if anything, I'm kind of on slack a little bit. In other words, I could take a little nap if that's happening. Now, let's look at the biggest difference between those two motions at the knee. Abduction, internal rotation, versus adduction and external rotation. This is caused by gravity, ground reaction force, mass, and momentum. This, we'll see, is caused by the mass and momentum of the success of the opposite side of the body as well as the success of all the muscles. So we have to say, who's tougher, meaner, ornerier, and more dominant, and there step by step by step by step in our life? And the answer to that is gravity, ground, reaction force, mass, and momentum. It's every step we take and every breath we make. And therefore, the force that we have doing that is a much greater force than we have doing that. And you go, okay, that kind of makes sense. But as you know, when we do that, the ultimate goal is to ultimately come out of that and go the other way. So I can take a step forward, so I can get the rebound and pivot, so I can go up and not only come down with the ball, but take off, so I can return to the ground after I spike, so I can actually load my foot and kick a soccer ball and come out of that. And so there's a lot of things we do that cause the foot to collapse or evert and cause the tibia to internally rotate and give you that relative internal rotation at the knee. Now, the other motions at the foot, it's predominantly at the subtalar joint and the mid-tarsal joint, are what we call adduction and abduction. And you can just simply stand on your left foot and already know where we're going here. If I take my body and rotate it this way to cause that foot to abduct, immediately that motion creates that valgus force to my knee, and literally as soon as even though it's coming top down, the calcaneus' ability to appreciate that and to evert and almost keep the tibia ahead of the femur in this case, even though it feels top down and the femur might be going a little faster than the tibia, as soon as that weight gets to the inside of the foot, that gravity and ground reaction force take over and force that internal rotation and abduction at the knee. And so just going into a little bit of more abduction, if I pre-position in the abduction at the foot, which you're going to see is external rotation at the hip, that all of a sudden we go, wow, that's putting us kind of at a greater risk there. One of the interesting things I noticed doing some cadaver work is that digging into the inside of the knee, that medial collateral ligament is a big, thick, wide ligament. I barely could find the lateral collateral ligament. It just was this little puny, kind of skinny little thing. And I'm thinking, I wonder why. Answer? Same answer. In other words, the medial collateral ligament has to deal with gravity, ground reaction force, mass, and momentum. The lateral collateral ligament only has to deal with the success of coming out of that. And rarely do we blow out of that so aggressively that we would need a good lateral collateral ligament, or that we would need a good PCL, or that we blow through that and cause a lateral collateral ligament PCL injury. Rarely do you hear of that combo. It's got to be a freaky, usually an external force injury for somebody to say, yeah, I blew out the PCL and the lateral collateral. It's like, okay, that's not a common thing. It usually involves some kind of an external force. So we have this internal rotation and this abduction, this eversion of the foot that creates, immediately you can feel and see and smell it at the knee, drives the knee in, drives the foot out and the knee relatively in here. So it drives it in the transverse plane, in the frontal plane. And then, of course, we have that other motion that we talk about in the foot and ankle, and that's dorsiflexion and plantar flexion. Now, it's not the foot off the ground dorsiflexing and the foot off the ground plantar flexing. It's the foot on the ground, and all of a sudden when I go into dorsiflexion, we know we already have had a stimulation of the posterior tib and the peroneus longus and the soleus and the gastroc, which is kind of neat because those want to decelerate calcaneal eversion, but it's also going to allow us to decelerate ankle dorsiflexion, and we know the soleus is the extender of the knee, and therefore it can create nice stability in the sagittal plane. But we also know that the soleus is a decelerator of internal rotation of the tibia. And not only does it do a nice job, but its buddy, the gastroc, can do the same thing. It decelerates ankle dorsiflexion, but as it grabs the femur, it decelerates the internal rotation of the femur as well and keeps the relative motion between the tibia and the femur kind of in sync, so you don't have a lot more tibial internal rotation excessively than internal rotation of the femur, and therefore the ACL goes, man, those are two of my best friends. The soleus and the gastroc, by far, two of my best friends. You get them going on early, I'm going to be happy. And my buddy, the posterior tib, big friend of mine. And my buddy, believe it or not, the peroneus longus that we thought was the thing that everted the foot, and it doesn't. It creates that same sagittal plane and even that same transverse plane and that same frontal plane stability to actually help decelerate knee internal rotation and knee abduction. So, what does all that mean? Well, it means that understanding our chain reaction biomechanics of the foot immediately gives us some hints as to what we can do first. So if I didn't know anything about you and I was going to start you on a performance program or prevention program or a rehabilitation program, the question is, well, what plane of motion would I like to stay in initially? And the answer is sagittal. Because yes, abduction many times is combined with internal rotations, combined with sagittal plane flexion, and we even sometimes see that with sagittal plane extension, but it's not the moment of flexion that causes an ACL tear. In fact, that flexion turns on the calf group, posterior tib peroneus longus. It also turns on the hamstring. Remember, the hamstring decelerates knee flexion. Remember, the quadriceps decelerates knee flexion. And of course, it turns on what we're going to talk about the next big friend of the knee is it turns on the hip, of course, in the sagittal plane. And it prepares those sagittal plane big butt muscles to help decelerate, you got it, internal rotation and abduction. So we immediately go, wow, we can take advantage of that. Understanding that I can look at this foot relative to what it does in little baby lunges, what this foot does if I just kind of put it behind me, hang onto the wall, and just do some pelvic slides in the sagittal plane and maybe add just a little obliqueness to get a little bit of frontal and transverse plane motion. Also, what this foot is doing when I do these baby lunges forward and back, to the left and to the right, rotate to the left and rotate to the right. Which one should I do first? Which one should I do next? Which one do I still need to do, be very proficient at, but which one does the ACL look down and go, hey, okay, I want you to be really good at that one, because if you don't decelerate that one and come back home, there's a good chance I'm going to take the hit. And so we go, whoa, this is pretty cool. And then we have to go, well, so what happens when this foot now leaves the ground and it comes and hits the ground at different angles or in different directions? Am I doing an anterior jump or turn into a jump to a hop? Posterior, left lateral, left rotational, right rotational, and knowing that ultimately we're going to have to get you to hopping and reactive hopping. How do I progress there? What's the safest way to get there in order to benefit my foot and ankle, to benefit the rest of my body, but to specifically benefit my foot and ankle as it relates to the anterior cruciate ligament? So as we look at our chain reaction biomechanics, one of the biggest things we can do that you've already done is take advantage of your knowledge and say, now that I understand what the foot does to the knee and what the foot does to the hip and what the hip and the foot and knee does to the foot, I can really go, this is kind of the chain reaction that I want to create with this particular exercise, is to get the foot to do that, because if it does that, I can turn on those proprioceptors, which turn on those muscles, which will immediately protect the knee, and I'm very, very safe. And we want to start safe. We want to end safe. But we're going to start relatively kind of less stress on the knee and gradually go to the greatest stress that we can safely tolerate in order to create what we're going to talk about in a little bit as a buffer zone. So understanding this guy as it relates to the rest of the body. Now, you've heard me allude to the other side as well. Understanding even what my right foot effectiveness pushing off can do to protect my knee is big time. So sometimes we'll see all of a sudden this collapsing, this left knee, but we'll look over here and see that this thing is the kind of the thing that let it down. So pretend that this leg is not doing what I want it to do. It's going to put too much stress on this leg. So sometimes we'll see what we call those bilateral engagement to the ground with a unilateral ACL tear, will sometimes always want to blame the leg where the ACL tore, but we have to be smart enough to realize that it's the right foot and the right hip many times that could actually be the failure that would cause an abnormal stress of internal rotation and abduction to the left knee. All we got to do right now is just appreciate that this foot moves in 3D, and we got to understand what we're going to do initially in the sagittal plane, and then what we're going to do in the frontal plane first. Probably take it out of abduction, and what we're going to do in the transverse plane, take it out of internal rotation initially, but gradually get it into that abduction internal rotation to teach the hip, teach the foot in this case, how to decelerate those motions, bring you back home, and you just get to enjoy life and know that you weren't even close to tearing your ACL, and the ACL is going to say, hey, foot, thanks, you're a great friend. The proximal knee is, without a question, the bestest friend to the knee. Here's what I mean by that. If I look at my knee, we're going to look at the left knee again. Look at it really close, and we're going to look at the left knee and the left ACL that goes that way, obliquely, from up here, down there, anteriorly and medially. We're going to say the proximal knee, which is the hip, see that going there, and the pelvis is the bestest friend. And that just makes sense. I'm not sure who's the bestest. Is it the foot or the knee? But if you look at all the glob around our hip, all this muscle, if you're really going to say, I want to depend on this bestest friend, the knee's always going to look up and say, come on, hip, do your thing. Because if you do your thing, then the opportunity to create an abnormal stress, to me, the ACL would say, is going to become minimized. Well, just like we did with the foot, we're going to look at the chain reaction biomechanics of the hip and then simply say, and so what? What do we need to know about that in order to understand what causes an ACL when this friend lets it down, and as important, what will be our progressions to bring it back home, or our progressions of prevention and performance, where we hope and pray that we never have to deal with an ACL tear to begin with. You already are there. You're understanding your chain reaction biomechanics. You're kind of getting a smile on your face and saying, I think I got this. I think I got this. And so we'll start like many times we do, just the power of gait. Because gait, kind of running forward and then picking it up to running, and then going where we're cutting and turning corners and stuff, and understanding the stresses, and then going from gait to not going so much translation across the ground, but up and down, and decelerating, again, the force of gravity, ground reaction, force of mass and momentum. If we can appreciate the hip and gait, we can then say, well, I can appreciate what you're doing to it yourself, the femur, which is the knee, and then I can appreciate femur, what you're doing to the tibia, which is the knee itself, and then, of course, I can appreciate what you're doing to the foot. So when we walk and run, as you already know, when the foot enters into the ground, calcaneus everts, bingo, talus down and in, bingo, takes the lower leg, drives it in, internal rotation. Believe it or not, just the mass of momentum and the leg coming through, there's a mass of momentum of internal rotation to the femur, as well as the tibia feeding the femur internal rotation. But because most of the force is bottom up here, we have relatively the femur internally rotating, and we have the tibia internally rotating faster, which causes relative internal rotation, which relatively creates a stress, in this case a good stress, a proprioceptive stimulus stress to the anterior cruciate ligament. So that baby, when that internally rotates, immediately, as soon as my butt feels that, in all my proprioceptors, not only in my leg, but in my fascia, in my trunk, it immediately turns on all these big muscles, which strangely enough are on the outside of the hip, that decelerate that internal rotation. So all these muscles here go, I can help decelerate that motion of internal rotation of your knee. You can just feel that. In other words, this whole glob, as it lengthens, allows this to happen. And because that's happening, because of gravity, ground reaction, force, mass, and momentum, and the fact that we're going forward in this case, what happens is it gets lengthened eccentrically like all muscles do, and if it successfully decelerates that, it's going to stop that. It's going to stop internal rotation of the femur and of the tibia and now bring us back home to allow us to then propel forward, i.e. walk. And so the knee is going to go through that internal rotation and then abduction, and it's going to go from abduction into adduction. It's going to obviously go from flexion, absorbing all that shock, that gravity ground reaction force, into extension. But here's the really cool part, which I think is the magic part of understanding your chain reaction biomechanics. It's going to allow a little bit of internal rotation, but because of all the muscles that are turned on here, especially the hamstrings and the quad and my adductors and my tensor fasciae lata and my calf and my posterior tib and peroneus longus, what it's going to do is now when it allows this other leg to come through, it's going to bring the whole knee back, and it's going to create, believe it or not, a little more internal rotation at the knee as it creates more internal rotation at the hip in order to give the hip more power to control the body and the hip more power to control the knee and the foot. Now, that was kind of confusing early on in our chain reaction. We described it. It's even confusing now, but it's really not. It's actually, I think, the econcentric nature of the hip and the rest of the body, believe it or not, is the part that we need to emphasize, that we really need to rehabilitate, that we really need to train and condition for our performance and prevention programs. That's the secret sauce to understanding the chain reaction biomechanics of the hip. Take a big breath. So we got this motion going on that as soon as those muscles get turned on, they will decelerate that and bring you back home. Now, here's how we create adduction of the left hip. We don't use our adductors. In fact, we have gravity. So if I'm just kind of standing here talking to you, and I get a little tired, all of a sudden you'll see my butt stick out on this left side. And you go, you got left butt adduction. Yeah, I do. Well, that's what gravity and ground reaction force does in gait. Well, combine that adduction with calcaneal eversion, and you're going to get a zigzag in all of us. And the normal zigzag pattern is adduction here, abduction here, eversion there, which makes sense. That loads the system in the frontal plane, which ultimately loads it in the transverse plane, which assists in the load in the sagittal plane. So we got the butt going through adduction, which creates this angle of the femur, which creates abduction at the knee, which the ACL goes, I like this. You're stimulating me. I have these proprioceptors inside me and all my other proprioceptors around me. We send information around and say, hey, friends, help decelerate this. Because it's the deceleration of this that's going to protect me. And we go, oh, that's pretty cool. So we got this internal rotation going on. We got this adduction going on. And obviously we have this flexion going on. Well, if you or any of the butt muscles, gluteus medius, gluteus minimus, gluteus maximus, obturator, gemellus, piriformis, any of that glob back there, and if I came up to you and said, so what turns you on? It says, well, what's kind of interesting is the two things that turn me on the most, in fact, the three things that turn me on the most, is when the distal part of me goes through flexion, abduction, and internal rotation. I go, oh, what do you mean? What do you mean the distal part? And then the butt muscles are just kind of giggling, going, I'm just trying to trick you a little bit. The distal part of me is my knee. So if you just take my knee and do what I just said, flex, internally rotate, and abduct, immediately these butt muscles say, these posterior butt muscles say, woo, I'm turned on. I'm lengthened. I'm eccentrically going into gear in order that I can slow that down, in order that I can take you out of flexion, get you into extension, take you out of abduction of the knee and adduction of the hip and get you the opposite direction, and use the power of the other leg coming through and the power of the transverse plane to get a little more length in the transverse plane into more internal rotation in order to protect my back, in order to protect my buddy the knee, especially my buddy the anterior cruciate ligament, and obviously protect my foot. And we go, okay. That sounds like the safest thing that we can do is to facilitate turning you on, maybe in the sagittal plane first, and getting you to do that well, and then maybe turning you on a little bit in the frontal plane and doing that well, but maybe turning you on in the transverse plane and doing that well, that will, because you're controlling yourself, hip, femur, pelvis, that if you're being controlled proximally, then you're actually being controlled distally. Is that correct? And the hip will go, you got it. Man, if you start to understand me, the hip, that way, and you understand the foot that way, you're going to have it. Now, we call that, in applied functional science, feeding in. Feeding in means to take a look at a motion that usually occurs because of mass and momentum, gravity, ground reaction force. And when that motion occurs, if we feed things in, it's going to help. In other words, it's going to give friends to the ability to decelerate that. So in this case, let's just think of a squat, which a squat is really 3D in function. When I go up after a basketball, it's 3D. It's not just sagittal plane. When I go up to hit a volleyball, when I go to plant my foot to kick a soccer ball, when I all of a sudden turn and change direction, it's a 3D squat. In other words, I'm getting flexion and adduction here. I'm getting internal rotation. I'm getting abduction, flexion, internal rotation here because I'm getting calcaneal eversion and dorsiflexion and abduction down at the foot. And so when those motions happen at those joints, we realize that all the friends are helping decelerate that and then allowing me to come back home. Well, as soon as I come back home, all of a sudden the anterior cruciate ligament says, wow, this is human movement's incredible, it would say. It's like the freakiest thing in the world because I get turned on going through these motions that if you go way too far, it's going to hurt me. But these motions right now are helping me turn on all my friends to decelerate exactly what we need to do the opposite of to protect me. And so the ACL says it's kind of a paradox that in order to be safe here, I got to go to where it's kind of dangerous, but not into dangerous territory. It's truly paradoxical. And so we'd go, yeah, that's kind of cool. Most of the function is paradoxical. Most of the strategies of applied functional science are paradoxical. Now, to sense that, to understand that, what we'll many times do in a live chain reaction, and I'd really appreciate if you do this with me now, and if you don't have time or the ability to do it right now, if you're driving your car and listen to this, not watching the video, hopefully you're not watching the video, just when you have time, here's simply what I'd like you to do. I'd like you to stand on your left leg, and I want you to do a squat. Just let it go. Now, if you really let it go and don't overthink it, you're going to do a 3D squat. Pelvis is going to drop. You're going to get adduction. Femur's going to rotate in, tibia's going to rotate in because the calcaneus says, man, if you're letting gravity take over, I'm everting, I'm taking my talus down and in, and you'll have a certain squat ability. And what's kind of fun is many times I'll say, hey, just barely toe touch on the right. Don't put any weight on that. Just toe touch and see how far down you can squat and come back home. See how far down you can squat and come back home and get an idea where you go. What's beautiful about that is human movement is the most reproducible thing we can do. And that's why, of course, we use human movement, authentic human movement with 3D maps. Then I say, did you do the best you can? And everybody goes, yeah, we did the best we can. In other words, did you translate down as far as you can, let gravity take over, but then stop all the forces that gravity's trying to take you down into the ground, suck you into the center of the earth, and then were you able to successfully come back up? Yep. Do me a favor. And they'll go, sure. This time, take your hands and reach them forward, but don't touch the ground. In other words, you can't cheat by giving yourself another point of stability. And everybody, I'll turn sideways, goes from doing this consistently to all of a sudden putting their hands forward and going much further down. And of course, I get a little grin on my face, and I let them do it 3 or 4 times, and everybody's going, so I said, so, you loafed on me, didn't you? What do you mean? Well, the first time I asked you to do the best you could, and you went so far. But now you went further. So you loafed on me. And they kind of look, I didn't mean to loaf on you. And then I go, no, you didn't loaf on me. I just tweaked in a little more of your back butt friend. What do you mean by that? As soon as I take my hand and I move it forward, I'm lengthening my butt in the sagittal plane. And as soon as that eccentric gets lengthened more, all of a sudden that butt says, You've put me at a mechanical advantage, a biomechanical advantage, a neurological biomechanical advantage, to now when you want to lower yourself, I can do more for you and take you down lower and come back and have a greater excursion because you tweaked me in. And everybody goes, that's pretty cool. If I've never experienced that before, that just seemed like I was more powerful. That seemed like I was a little safer. That just kind of seemed right to me. And then I go, now, we would not do this as an acute progression. We would take it a variable a lot less, but just for fun, take your hands now and put them straight over your head. In fact, put them behind your head a little bit. Stand just on that left leg and now try to squat. And as you can imagine, especially if you're experiencing it right now, we ain't going to squat very far. And then I kind of get a smile on my face again, and I go, so did you get heavier? Nope. Did gravity get more aggressive? Nope. What happened? Well, we took a friend away. We didn't tweak in, we tweaked out. So we basically said, let's tweak out the butt and the sagittal plane. So with my hands here, I put you in an extended position. The glutes can't lengthen eccentrically, and as I go down, the glutes look down and go, hey quad, hey ham, hey calf, hey posterior tib, hey peroneus longus, hey adductors, hey everybody. We can't help as much as we normally would because Gary has me holding my hands over my head. So he's tweaked this out. And everybody goes, oh, that's pretty cool. Then obviously there's some place in between here where this is really a mechanical advantage to, okay, this is kind of in between all the way to a mechanical disadvantage in the sagittal plane. You already know where I'm going. We're going to matrix this sucker and say, well, the same phenomenon happens in the frontal plane and the same phenomenon happens in the transverse plane. Now, the frontal plane is an interesting phenomenon. Here's what I mean by that. If I'm on my left leg and I take my hands and I take them to what we call right lateral at overhead, and then I squat, I'm going to have more adduction here, which is going to turn the butt on a little more. And so I'm going to have a certain squatability. Now, if I then take away the butt in the frontal plane, which I could do by what? Taking my hands the other way. So I'm again talking about this left leg. Now I don't have that adduction. I have brought the hip back to kind of neutral to maybe a little bit of abduction. Now when I do this, it's a whole different feel. Now here's the problem with that though is, not necessarily a lot harder, because when I go this way, I change the center of gravity, so I increase the lever arm of the axis. When I go this way, the lever arm of the axis is less. So because the lever arm is greater here, that makes it harder, but because I got my butt turned on in the frontal plane, it makes it easier. The other way, the lever arm is less, but the butt now is not turned on in the frontal plane. So there's a plus and a minus in the frontal plane that to me is quite intriguing. However, knowing that we're talking about this in reference to the ACL, what I do is I go, okay, let's do this, and let's take our hands and go this way. Immediately, this adduction drives this left knee into adduction. So immediately as I do this, the ACL goes, not much going on here. I don't feel much stress. But as soon as I do this, when I go this way and I feel this abduction here and this knee wants to go in abduction, the ACL wakes up a little bit and says, well, what'd you do there? Well, I took my hands from right lateral to left lateral, and I created a different frontal plane stress on the hip and therefore on the knee and on the foot. So the safest in this case would be, if you're talking about the ACL, would be basically the longer lever arm, but turning on the butt in the frontal plane to make it successful, where we progressively go this way. That makes sense. Now the magic one, the transverse plane. Not magic, but yeah, it's magic. It's the transverse plane's got something going on that we haven't quite figured it out. And of course, anytime we can't figure it out, we'll say, that must be magic. And a lot of people say, it's just understanding your biomechanics. And I go, I don't understand it quite yet, but let's call it magic. Let's start real easy. If I stand on my left leg and I toe touch all the way around, so my pelvis comes and my femur starts to externally rotate, you know that's internal rotation now. Before I didn't. In other words, when I saw that femur externally rotate, I said, well, that must be external rotation. But you know that the pelvis is going farther than the femur, faster than the femur, because I'm driving from this leg through the pelvis, and therefore that's internal rotation. If you're in transformalizing, becoming the butt muscle, you're immediately saying, ha 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 ha, guess what? I like that because I'm being lengthened. And therefore, if I do that, and then I do that same squat test without doing anything else, I'm toe touching here, and I squat, I can squat down pretty good. I can really, in fact, I squat even further than I did when I was facing you. However, if I then take the posterior butt out of it, like we did in the sagittal plane where we went from flexion into extension, if I take the posterior butt out of it by doing this and trying to say, okay, anterior medial butt, you're going to have to decelerate this. And the anterior medial butt says to you, hey, have you seen me lately? Look at my back butt. A big glob, big glob. Look at this here. Not a big glob. Not much going on here. So as soon as I do this, and then all of a sudden I start to squat, not only do I feel this excessive rotation of my knee and mostly abduction, but as soon as I do that, I feel my foot quickly evert, which causes ground up internal rotation. And I feel even more internal rotation of the whole leg because the pelvis is driving the femur into internal rotation. But what I don't feel is anything slowing that baby down. I'm kind of looking for something to slow that down, and my front butt says, I ain't got it. I ain't got nothing for you. And we go, ooh, that should be a consideration. And so we go, big consideration. So if we just kind of say, the transverse plane seems to have safety with internal rotation and a little less safety for the knee with external rotation, seems to have safety with flexion, a little less with extension, seems to have safety with adduction and less with abduction. We need to keep that in our mind, especially when we design our chain reaction exercises program and say what's first, what's second, what's next, and what's ultimately last. In chain reaction, we finally do this, and this is kind of a fun one. I usually get a giggle. You may or may not giggle, but I always thought it was funny. So I'll say, now do me a big favor. Stand on your left leg, toe touch. Be careful now. And let's take our hands and posterior at overhead reach, which takes the hip out in the sagittal plane. Left lateral reach at overhead takes the hip out in the frontal plane. And let's open our shoulders and rotate our hands to the right as far as I can. And be very careful now. And now try to single leg balance, do a squat. And you'll barely go down and you'll barely come up. And of course, then I'll say, you ain't got what? And most of the crowd goes, you ain't got squat. Well, you got squat, but you don't have many friends. You fed a lot of your friends out by where you just put your hands. And so what I'll then do, very typically, is I'll go, so I have grandkids now. And I can remember with my two sons praying all the time that, man, I want them to have fun. I want them to have a healthy career. I want them to run around and just play to the heart's desire. But dear Lord, I don't want them to have to deal with injuries. Now, can't prevent it all, but one thing we did is we prayed about it. And the other thing we did is we worked hard on our chain reaction biomechanics, taking them from what we call a feeding in strategy to gradually feeding out. And so I said, so I get to visit my granddaughter who's playing volleyball, and she's 4 to 5 weeks into her program, and I asked the coach, can I come and watch their training? And the coach says, yeah, sure, you'd be happy to. We let grandparents come. And so I come, and all of a sudden I see my granddaughter doing a program with their athletic trainer or with their physical therapist or with their strength coach or even with their coach, because a lot of schools don't have the luxury of those other professions. And the coach has my granddaughter, in this case, the strength coach has my granddaughter standing on her left leg with her hands behind her to the left and rotated to the right and just doing little mini knee squats, explaining to them we're going to go a little faster and maybe tomorrow we'll add a little weight, which is putting her at a huge mechanical disadvantage. If I could put a microphone to the ACL says, whoa, kids, talk about internal rotation ground up because of the calcaneal eversion. Talk about mechanical disadvantage, expecting my my middle butt, my inside butt, anterior medial butt to protect me, I'm feeling service nervous here. I feel like I'm really close to tearing, and therefore I'm not so sure about this. But then the rest of the body goes, yeah, but we've gradually progressed to this, and we know you're successful. This isn't day 1. This is week 5 or week 6 of your training and conditioning. And so I see her doing that, and I immediately go, jump out of the bleachers, and I run down and I go, who's responsible for having my granddaughter do this particular exercise at this time? And strength coach, she raises her hand and goes, I am. And I go, I don't know what you're getting paid, but I'm going to go to administration and ask them to double or triple your salary. Because I got a feeling that you gradually progressed my granddaughter, at least from the top down, through the hip, where she's successful in the sagittal plane and gradually tweaked the friends out, that you took my granddaughter and took her from the frontal plane and gradually tweaked things out, and that you took my granddaughter from the transverse plane and gradually tweaked things out, knowing that my granddaughter, being an outside hitter, is going to be coming down on her left foot with her hand in this exact position. And if she hasn't been training for that position, how is she going to, the proprioceptors know to talk to whoever the friends are left to say, we have this. In other words, some friends are gone, but we have this in the trunk predominantly. We have this distally at the ankle. We can decelerate that. Don't worry about it. Because if she experiences that particular movement for the first time during practice or play, she will tell her ACL. And so it's kind of like, wow, this kind of makes sense to me. So, a big friend to the knee. It is the knee. The foot, a big friend to the knee. It is the knee. Now we're going to go a step away from the knee for our last big friend. And in just a little bit, we're going to talk about the power of the trunk, and then we're going to put this all together. So it's kind of fun to transformalize and become body parts. And as you know, in this case, we're becoming the ACL. And the ACL by now is saying, I really appreciate the fact that you know that I really am the foot. And that what the foot does impacts me directly. And the ACL would say, and I really appreciate the fact that you really know that I am the hip. And what the hip is able to do impacts me directly. But what the ACL would say right now is, I want you to understand that the trunk is probably the most underestimated part of me. In other words, it's another one of my bestest friends. And it would say, when you think of the trunk, yeah, think of everything from nose to toes. But in this case, just think of things that happen kind of with the shoulders and the core down to the hips. We've already talked about the hips. And it's going to say, predominantly, I want you to think about the thoracic spine. Because when the thoracic spine moves, and it has this amazing ability, like the hip, to move in all 3 planes of motion, it has all kinds of flexion, it has all kinds of extension, has all kinds of lateral flexion to the right, lateral flexion to the left, has huge rotation to the left, huge rotation to the right. And what's wonderful about the core is most of the good stuff's in front. In other words, when you look at the thoracic spine, yeah, we got all those posterior spinal muscles and the thoracolumbar fascia and the latissimus and the rectory and all those and all the scapular muscles. But when you come around here, there's a pretty good slab right here that we need to take advantage of. And the ACL would say very few people understand how to take advantage of my core, and especially my anterior core. And I would say to the ACL, so, you want me to do a lot of sit-ups, huh? And the ACL goes, I know you're just teasing. I know you're just being a little facetious there. No, that's not what we do. I do want you to train the core to help decelerate motions of yourself that will help decelerate motions of the hip and the foot that help decelerate the motions of abduction and of internal rotation. And I go, well, wait a minute. This is that chain reaction biomechanical stuff again, isn't it? And the ACL says, yeah, you got to know it. You got to know it. But the ACL would say, but in this case, if you train the core properly, you'll be surprised that when you think you're at a mechanical disadvantage because some of the friends, such as the foot, some of the friends, such as the hip, are in a position while moving that isn't going to load them well and allow them to explode to get me out of danger, if you train the core properly, the core has the ability to do that. Now I'll go, well, okay, I hear you talking, ACL, but I don't understand what you're saying right now. And the ACL says, well, let's just look at the relationship again between the core, the thoracic spine, and the hips. Because you guys have a really good understanding of the hips relationship, because the hip is the knee, and the relationship of the core to the foot. I'll go, okay. And so it'll say, well, usually when you're flexing the hip, you get relative flexion of the core. When you guys squatted, not only did your hip flex, but you guys flexed your trunk if you were able to do so. However, when Gary had you take your hands back and weren't able to use your hip as much, all of a sudden we would say, well, could I possibly use the core to help decelerate that flexion? And the core would say, yeah, if the hip can't do it, here, I have the ability to do that. So if you're going into total body flexion and your ankle can't do it and your knee can't do it and your hip can't do it, the core would say, I can do it. And I have some pretty big, strong muscles back there in order to turn that on. But then the ACL would say, yeah, that's of interest to me, but that's not when I'm at a mechanical disadvantage. I'm at an advantage. In other words, I feel very well protected when everything's flexing. As you can feel and see, I feel very strong and kind of cocky down here. It's in the sagittal plane, but even in the other two planes. But as soon as my hip goes into extension, all of a sudden, the ACL says, now is when I get nervous. But interestingly enough, when the hip goes into extension, guess what? Our thoracic spine has the opportunity to go into extension. So now, even though I can't decelerate that well with the front hip, I can decelerate this motion quite well with the front core, or what we would call the anterior core. And you go, well, those are the abdominals. Yes. And it looks like what you're doing is you're extending and decelerating extension and coming back into flexion. Yes. And just looking at my knee during that, if I'm able to get here and then come back home, all of a sudden it puts my knee in a safety zone. And you go, that's pretty intriguing. I kind of like that. And then the ACL says, well, let's look at one that's a little more easier to see. You remember when we did that side-to-side thing where here it put us into adduction, it put our knee into adduction, and it literally kind of put us in a little bit of inversion? I go, yeah. And that was a mechanical advantage, but then we went here and put us in a mechanical disadvantage. Yeah, that makes sense, because now we're not adducted, loading all the posterior lateral muscles. Now we're going into abduction and trying to load some muscles here that just haven't been trained very well to decelerate what's happening at the knee. And the ACL says, you also remember when you did that, it also added a frontal plane stress to me, the medial part of the knee, and created a little more stress on me, not only my buddy, the medial collateral, but me, the anterior cruciate. I go, yeah. What the ACL says is just keep looking up the chain. And I go, what do you mean? Just watch. So if you're going here, look up the chain and look what you have here. You have left lateral flexion. Yes. Well, what if you train these muscles here? When it felt that left lateral flexion, to decelerate that, in fact, kind of do it in slow motion, Gary. What do you mean? Let it load, put me at risk, the ACL would say, but then explode. Boom. When you go look here, I want you not only look at the trunk, but look immediately at the knee. Watch what the knee does. I go from left lateral flexion to right lateral flexion, or just coming even back to neutral. My knee goes from abduction, and it comes back home. So I go from stress on the ACL to less stress on the ACL. Stress on the ACL to less stress on the ACL. Stress on the ACL, less stress on the ACL. I'm going, oh, cool. I get it. I see where that's going to be huge if I know what the hands and the trunk are doing relative to the hip and the feet in order to put you at a mechanical advantage, or if you are at a mechanical disadvantage, how to get the core to help get you out of danger zone. And the ACL would say, you got it. But the ACL would say, look at this one though. When you take me and you rotate me this way, which puts creates internal rotation. Again, we're talking about the left ACL, the left knee, the left limb. And I do this, the pelvis comes over, all of a sudden that hip goes through internal rotation, I'm lengthened, I feel very safe. I just feel like, even though I got relative internal rotation going on, not only at the hip but the knee, I have very little relative motion going on because I'm going into inversion, and I have adduction going on. So that little bit of internal rotation, a lot of adduction, I'm happy. Very little stress on my life. I'm not talking much because I'm not being lengthened, and my proprioceptors aren't being turned on. And in fact, it would say a lot of people realize now I'm not a ligament that controls movement. I'm a ligament that feels movement, that turns on proprioceptors to turn on muscles that control movement. And go, and that changes the game, because back in the day, we felt you had to be at a certain strength in order before we'd let you come back and do something functional. They go, no, your heart was in the right spot. That's not what I do. I'm not a restrictor of movement. I'm more of a sensory organ. I go, okay, that was a nice little sidebar. But then the ACL would say, now, remember when you went the other way? And you externally rotated and you barely could do anything, but that external rotation did two things. It drove the foot into more eversion, which drove the tibia into more internal rotation. But at the same time, it drove the hip into abduction, and it drove the knee into more abduction. And of course, it drove the hip into external rotation. But because I have so much calcaneal eversion coming from below, especially when I take this foot off the ground, especially when I start hopping, that I have kind of the worst of two worlds for the ACL. Huge top-down abduction and huge bottom-up internal rotation. And so the ACL says, I'm getting to the point now where I'm talking a lot, and I'm asking for everybody to help me. But the ACL would say, but in this position, especially if you got a little hip extension, and obviously we got the hip abduction and we have that external rotation, I'm looking around the body to help. But we already know where we're going. Watch what happens now if I continue this all the way up into the trunk. And so the abdominals go, that's us. That's us. Look at this. I can decelerate this motion and bring you back home. Just watch this right shoulder go from right rotation to left rotation. Nah, don't just look at my right shoulder, watch my left knee. Right rotation, I'll do it in slow motion. As soon as this comes back, this muscle grabs, brings me back home, grabs this pelvis, brings me back home, grabs the femur and brings me back home. So you go, whoa, that's in the huge range. So in that position where you ain't got squat, you remember that one, Gary? I go, yeah. I remember when we were kind of like this, and we were like this, and we were like this. Well, we ain't got squat at the hip, but we got some squat at the foot. We got the posterior tib and the calf working really hard, and the peroneus longus, got it. So I got to understand, I'm going to really try to take advantage of that. My hip's at a mechanical disadvantage, but Gary, it looks like my trunk's at a mechanical advantage. Yes, it is. It's a mechanical advantage of the anterior core because I have external rotation to the right, and I have lateral flexion to the left, and I have extension at the same time. I have a 3D lengthening of the abdominals. And the 3D lengthening of the abdominals, the ACL looks up and goes, that's the real secret sauce. I go, what do you mean? If you can understand how to drive me from the bottom up and from the top down and drive me in all different directions and use gravity, ground reaction force, and the mass of momentum, and understand that no matter what movement my body goes into, that I have been gifted, the body will say, with proprioceptors to be turned on, in this case through the thoracic spine, to turn on muscles that if this muscle is taught to do this, it will decelerate that, bring the knee back home. It will decelerate that, bring the knee back home. And it will decelerate that and bring the knee back home. And I'll go, whoo, that's big time. Because that's something I can go after day one, even after, let's say, a surgery. Let's say I'm partial weight bearing and I can at least get some thoracic extension going. I can get a little bit of frontal plane thoracic motion going. I certainly can get a little bit of transverse plane motion without any disruption of any surgery. And it seems like I would want to attack and consider and facilitate movement in the thoracic spine to turn on the abdominals day one in a performance and prevention program. Exactly. Exactly. And so the ACL would say, man, if you got this figured out, if you understand to get the core going, and even now looking at the core relative to the shoulder girdle here, posterior shoulder girdle here, boom, it protects, watch this. This posterior shoulder girdle protracting, when it retracts, those rhomboids just save my knee. On this side, my anterior shoulder girdle, when I rotate to the right and it contracts, all of a sudden come back, just protected my knee. So you mean the scapular muscles can be subconsciously, purposefully trained in order to, when it senses that the knee is going through motions that put the ACL at risk, that they can subconsciously be taught to turn on, decelerate the motion they're going through, and then go the opposite motion to bring the knee back home to protect my buddy, the ACL? Yes. But it has to be done in these positions and with these movements to facilitate these motions in order to facilitate the desired chain reaction. Now, the beauty of all this is all we have to do is step back and go, okay, I'm going to consider the foot and the hip and the trunk and the shoulder girdles in everything I do, and I'm going to initially start with a strategy of putting everybody at a mechanical advantage. That's where I want to start. That's where I want my granddaughter and grandson to start. That's where I want a 4-year-old to start. That's where I want an 84-year-old to start. No matter what they're doing, in order to get them to move and jump and locomote and do things better. And especially if I'm considering the ACL. It's definitely where I want to start with my rehabilitation program. And knowing that, I can start a lot of things a lot sooner than I ever dreamed, because a lot of these initial motions put my knee not at risk, but actually protect my knee. But we'll gradually go into the zones that make it a little more challenging, but it's the zones that we definitely need. We have to ultimately get back to full abduction and internal rotation so I can effectively jump. And we have to get back that so I can effectively run and propel, so I can effectively do all kinds of things. Back in the day, again, I think we were all part of it. I know I was. I think our heart was in the right spot, but our brain wasn't. In other words, we thought, man, if we could just keep the knee safe and keep the knee over the foot all the time, that there's no way that that's going to happen, and no way that that's going to happen. Well, if I take that away from you, I take everything away from you. I take your power. I take the frontal plane from you. I take the transverse plane from you. I take your entire calf, posterior tib, peroneus longus. I take all of your butt muscles away from you. And if I try to do that, I'm going to take your core muscles away from you, because you can't get into the load. So we need to progressively go from this adduction, kind of external rotation, minimal internal rotation, and gradually feed, so we get more internal rotation, more abduction at the knee, but not only teach it to get there, but teach it to subconsciously, very aggressively, very reactively to come back home. The only way we can do that is with what we call proprioceptively rich exercises. Those that are subconscious, those are quick, those that are talking the foot to the hip, the trunk, and the shoulder girdles in order to do that. And when we come back, we'll take a look at those strategies and kind of break it down again through what are the considerations that I would do relative to the foot, what are some considerations I would do to the hip, and what are some considerations I would want to have relative to the core, and then what are considerations relative to the action. Because the actions relative to the planes of motion and how we tweak friends in and tweak friends out have to go along that parallel. In other words, it's not do this, do this, do this. We're doing a zigzag pattern where we'll do this here with this action here, but that action with a different plane of motion, this action feeding a lot of things in, but this action feeding a lot of things out. Our progression to make our knee and our hip and our foot and our trunk and our entire body successful is a big dynamic spherical zigzag pattern where we go from where it's really safe with not very much stress to where we ultimately go where there's a ton of stress, and relatively speaking, not many friends helping, but the friends that are there have been trained to help, and therefore we don't put the ACL, the knee, or that wonderful, wonderful human being at risk.
Wow. If you are like me, you're thinking that was a lot of amazing information. So I just simply want to give props to, of course, my father, but Dr. Gary Gray. not only for how he delivered that information, but ultimately how he, alongside Gray Institute, is synthesizing 45 plus years of information to provide to the movement industry, because we know we don't know it all, but we want to know more so that we can continue to do more for our patients, clients, and athletes. Now, if you are like me, you're probably thinking, I do want more, so I can't wait for part 2. So just let me give you a quick glimpse of what part 2 is going to consist of. It'll have 3 big rocks, and the first big rock is going to be the dynamical systems approach, which talks about tweaking up and down based on demands, as well as tweaking in and out based on resources. The second big rock is going to be diving deeper into those said demands and resources specific to movement applications for the ACL. And then the third big rock is going to be honing in on Gray Institute's progression of jumps and out of sync jumps and even hops from a 36 360s progression, which hopefully you don't know much about, but you're going to want to learn more about. So as we come to a conclusion here of part 1, I just want to emphasize not only how great Gary did, but more importantly, the information that was covered. You know, Gray Institute, through what Gary has said for many, 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 many years, is that, you know, the knee is special, but it's caught in the middle with few places to go and no place to hide. It's susceptible if its friends are not assisting it. That's kind of like life in general. The more friends we can have supporting us, the better off we are, and the knee is no different. So if we can understand more about the foot biomechanics and the hips biomechanics and the thoracic spine's biomechanics in conjunction with the knee and the rest of the body, oh my goodness, not only are we going to start to protect the knee more, but we're going to start to protect the entire body more and get more out of it. So on behalf of Gray Institute, I want to thank you for going the distance in this extended webinar. And on behalf of Gary, myself, our entire team, please know how much we appreciate you, not only for your time you've given us here, but the time you dedicate each and every day in getting the most out of the patients, clients, and athletes that entrust their care to you. We are proud of you, and we want to thank you.
Thanks for joining us here on the Gray Institute podcast. At Gray Institute, our goal is to do one thing the best we can, and that is to help you become the go-to movement professional. If you have a question for future podcasts or questions about anything Gray Institute offers, including education, live or online specializations, or mentorship, please email us at info@grayinstitute.com. Be sure to look for our next podcast coming soon. Have a great day.